This week, what I'm super stoked to share with you all is basically a conversation I had with my favorite critical care doctor. No offense to the other amazing critical care doctors out there. You're all great, but my favorite is Dr. Terren Trott, University of Kentucky. He is dual boarded in critical care in emergency medicine, and he's ultrasound, so he's triple boarded. He's ultrasound fellowship trained as well. He's the ultrasound director for the emergency department at the University of Kentucky. Great person. We were at a conference in Las Vegas with our significant others, and we had a phone, I had a little tripod, and we decided, hey, let's talk about this thing that's important to us, and that is using ultrasound adequately in cardiac arrest. We're going to talk about a couple of other articles, but the main one is actually using the linear probe to actually do a pulse check rather than to look at the heart, right? So there is a lot of, discussion about ultrasound causing delays in pulse check, which I hate that ultrasound has been associated with delays in chest compressions, prolonging pulse checks. But it's really the way how you use ultrasound cardiac arrest. You just have to know how to use the tool correctly. But I think that maybe after you've already identified that the patient doesn't have a reversible cause, maybe the cardiac echo shouldn't be used for pulse checks, but rather the linear transducer looking at one of the big arteries, either the carotid or the femoral, maybe that's what should be used during the pulse checks rather than looking at your echo every single time. Check out the podcast and let me know what you think. Welcome to the Ultrasound Podcast. Terren, it's been so freaking long.
It's been too long.
So the last time that we actually sat down and did something together was the Critical Care Core Ultrasound Conference.
Yep.
I said that wrong. The Core Ultrasound Critical Care Conference.
The CCC.
The CCC.
Which was awesome.
CUCC, actually. I don't like that. We're not gonna use those syllables. It's just the Core Ultrasound Critical Conference. Critical Care Conference.
Yeah.
Yep. And that was great because we looked great from the waist up and also great from the waist down, but in a different way.
Yeah, it was Zoom time. Zoomland. We were in Zoom universe.
It was COVID central.
Yeah.
And we were very good at Zooming because that's all we've been doing. And we looked very professional.
Yeah, business on top.
And then we had short shorts and
tube socks. Nobody had to know.
Nobody had to know, and I'm really glad that we didn't take any pictures whatsoever of the event or any videos of the event at all.
Yeah, there's definitely no evidence anywhere.
There's no evidence whatsoever that we looked that ridiculous. We are in Vegas together.
That's
so
right.
This is great. We're actually here for not work-related stuff.
Right there.
Yes. Our significant others are here on a conference, and we're here just like hanging out. We've been chilling.
Being the troublemakers.
And then we were talking yesterday, and we're saying like, hey, like, what could we talk about? And we mulled over a few things. We're talking about like subclavian lines, for instance, because we both really like ultrasound guided subclavian lines. And then we started talking about these like studies, because this is actually true. Like, may I say that I think that you really like medicine?
That's true. That's quite true.
I
enjoy my job.
I also enjoy my job.
I like going to work.
I also like going to work, which is, I realize that it's not everybody, but I really like going to work. And so when we're like on vacation, which that's essentially what we're right now, we talk about ultrasound articles.
Absolutely.
We like this stuff.
Yeah.
And so we decided like, well, there's a couple of new articles on cardiac arrest with ultrasound that we should talk about. Now, I do have to give a little bit of, like a preamble about the kind of, the more common discussion in ultrasound and cardiac arrest.
Yeah.
And that is?
How long it takes.
Right. Because there's those two studies.
Yeah.
That at first I was like, ugh.
They brought a lot of kind of negative attention to ultrasound and cardiac arrest. Yeah. They were prolonging time off the chest, and nobody was happy about that.
I know. And it was a few seconds. And it was two studies. They showed a few seconds the ultrasound was used, and they were like camera studies basically.
Yeah.
So it was you don't really get they didn't have as much problems with like the Hawthorne effect, like how you change the way that you act because you're being like watched. So I believe it, but also that's the thing that I always talk about is the ultrasound machine is an inanimate object, right? It only does what the person holding the probe tells it to do, and 10 seconds is 10 seconds.
Yeah.
So I don't know. What do you think? Are you happy about this study, or like, what's your thoughts?
It was always
these studies, the old ones.
These older studies. I think it was important that they were done so that we knew to make some practice change.
Agreed.
And I feel like now, if you were to redo these studies, you'd have better outcomes, or you would have shorter times off the chest.
What do you mean?
Well, I just think, like, the public announcement that ultrasound is delaying time back on the chest, that once that kind of, like, we talk about it, we podcast about it, people are aware. So maybe that's not necessarily the case anymore. At least I would hope, right?
Interesting.
I would hope that now we're not impeding time back on the chest to resume compressions.
Brilliant. So I'm trying to think, like, there's this other like topic that I think something similar happened. It's with fluids, right? Like early goal-directed therapy, right? Like where you had this study that came out and it showed that if you follow these things, like mortality dramatically decreases. We did other studies that were like, oh, actually it might not do as good a work as the initial study talked about. However, we didn't even I don't know, but I don't think we even talked about fluids before early goal-directed therapy.
And it was at least we were highlighting sepsis.
Right.
You publish these goal-directed guidelines. Now everyone's talking about sepsis. Everyone's like, oh, I hate them. I love them.
Right.
It doesn't matter. At least we're identifying and we're getting that benefit of, maybe earlier aggressive care in a patient population that we were ignoring, I guess.
Yeah.
I don't know.
No, you're right. And so I think that those are good.
Yeah.
Now, we should talk about like the heart in cardiac arrest in general, right? So there's different ways that you can use ultrasound cardiac arresters that I usually think about. It's procedural, pulse checks, and identifying reversible causes. Now, I think procedural and identifying reversible causes, like that is still great, right?
Absolutely.
Now I will say that if I don't know, I'm like 3 to 5 pulse checks in, if I don't see a reversible cause at that point, like I'm not.
The ultrasound's kind of done.
It's just unlikely that someone's going to develop tamponade.
Yeah, exactly.
After they've already arrested from hypoxia, for instance, right?
Yeah.
So I usually don't pass that. What about you?
Exactly. I mean, you're looking for those big immediate things initially, and once you don't find them, I don't really need to know if the heart's doing this or this.
Right.
It's too gray. I need an A-line. I need some other information.
Of course.
But those subtle changes, of course, picking up like VFib, right?
Right. Yeah.
That
it can be helpful.
It looked like asystole, but on ultrasound we're seeing it's VFib.
Yep.
So there's a reason to continue using it, but I think you get diminishing returns after those first couple scans.
Yeah, and I agree. And then procedural, there's no doubt about it. Although I will say that if, let's say for access, right? Like if I have a patient that's dead, because remember, we're not doing CPR on live people, they are dead, right?
Yeah.
I mean, essentially, right? They're not perfusing enough.
Yeah.
Although
it has happened.
Or it has happened. I go for the IO.
Yeah.
Because it's faster. And then as I start pushing drugs that way, and then I work on either, a femoral, a subclavian, or an IV.
Yeah.
Right?
Yeah, exactly.
Now, the other thing is that sometimes I'll say 85% of the time I'm getting an adequate view on my pulse checks of the heart. 15% of the time I'm not getting anything.
True.
I don't know. I don't know. You might be different, but that's probably my average.
Yeah, well, we do TEE now, so 100 we get 110% of the time.
That is amazing.
Actually, that's not even true. I'm already thinking about that one patient that had pneumomedis down. I couldn't see hardly anything. Even with the TEE. But yeah, no, you're totally right. Yeah. It's not always going to be reliable because body habitus, crepitus, etc. All sorts of reasons we might not get good cardiac images for sure.
Yeah.
For sure.
Yeah, agreed. Now,
let me ask you this. When you're doing your cardiac ultrasound during your rhythm check, your pulse check, are you ever using what you see on the heart to say, hold off on compressions?
Rarely.
Rarely, right?
Yeah. I mean, if I see it, but it's so subjective.
Yeah, someone's, palpating carotid, palpating femoral, and you may see something. I'm assuming this situation would be strong, organized cardiac activity, but they say, I don't feel a pulse. Would you ever say, don't do compressions?
I have, actually. I definitely have.
When you saw good cardiac activity?
Yeah, but it has to be good. It has to be vigorous cardiac activity. It can't be they were asystolic and now they have maybe an EF of 15%. It's not that. It's they went from asystolic to 100% ejection fraction. That's the times when I do it. The gray areas in the middle, I need something else.
Yeah, I debate that. I'm sure I have as well. I was worried about some kind of obstructive process, though. It's like, so for example, now you got great heartbeat, but they're in hemorrhagic shock. So
right, but in that case,
don't have a pulse.
Chest compressions wouldn't do anything for that anyways, right?
Yeah.
And so, amazing point. I don't know if somebody has like a complete, like past massive P, a complete P.
Yeah.
I don't think that the heart would ever have an 100% ejection fraction, right? Because it just wouldn't have anything to like fill.
It's a good question. That's for sure.
Yeah.
I'm going to take a brief pause here just to let you know that all of our content is on the coreultrasound.com website. That is Ultrasound Podcast, 5 Minute Sono, Ultrasound of the Week, Clip Bank, and we also have our courses page where we have the Core Ultrasound Fundamentals and Core Ultrasound Question Bank, where you have 3,200 questions with feedback, including narrated videos explaining the question. Check it out, and back to your video.
What we have today, the 2 articles we're looking at, because
there's a lot, by the way, but we're going to talk about 2.
We traditionally think about ultrasound in arrest as looking at what the heart's doing, but now we're talking about how can it actually affect our pulse checks.
Right. The reason I love these is because there's 3 things I want in every arrest. It's airway stuff, it's an IO or vascular access, and it's an art line, right?
Yeah.
But we don't always have art lines. And so these studies talk about like how we can use ultrasound in lieu of art lines.
Yeah.
What's the first study we're going to talk about today?
The first study is out of resuscitation. We were just talking about how much we love that.
I know. No, props to Resus. They always have like
stuff.
Such interesting good stuff.
It's always like, I know I'm going to want to read it.
Yeah.
So this is point of care ultrasound compression of the carotid artery for pulse determination in cardiopulmonary resuscitation.
Okay.
And this was out of South Korea, published 2022.
All right. Yeah. So this study is great. I'm just pulling it up right here. This study is amazing, by the way.
Yeah. And, it's not a new concept. Like, we've seen this for years. People will put a linear probe on an artery and interpret it somehow to mean something.
Right.
But for a long time, there hasn't really been any data to support that practice. So I'd usually recommend people not do it, because I'm seeing what you're seeing too, but what does it mean?
Right. What do you do with it?
Yeah. Okay, great. I saw what you're saying, but how are we going to work it in? And so I think we're going to kind of get to that with these 2 articles.
Right. So what they did is they basically, why don't you do you want to tell them what they did or what the results were? What do you want to do? Or you want to do the whole thing? You want to do the whole thing?
No.
You do the whole thing?
Take the whole thing.
Okay, all right. Well, you pick what you want.
So their technique.
Okay, you talk about their technique. Okay.
So they took a linear probe, they put it in the transverse axis on the carotid.
Yeah.
Visualize the IJ, and their goal was to determine whether or not a pulse was present. So they compressed to the point that the IJ compressed completely.
So that was their marker to know that
We've pressed hard enough.
This is our spot. This is our endpoint.
Yeah.
Have we collapsed the IJ?
We've collapsed the IJ, and now we're going to interpret the carotid. So the carotid, if it was pulsatile, there's a pulse.
Okay.
If it didn't compress all the way, there was a pulse.
Okay.
The inverse was if it did compress all the way and there was no pulse, there was no pulse.
Interesting. Okay. It seems easy, right?
It seems straightforward.
Straightforward and genius also, right? To actually evaluate this. So they included 25 cardiac arrest patients. So not a lot of patients, but they did include 155 pulse checks.
Yeah.
And we're not going to go into all the nuances of inclusion, exclusion. That's something for the Ultrasound Gel podcast.
Read the articles.
Read the articles or listen to the Ultrasound Gel podcast, which I'm sure if we haven't already covered this, I'm sure we will at some point. They showed that when you use the ultrasound to look at the carotid pulse check, that the average time to identification of that pulse check was 1.62 seconds compared to 3.5 seconds with manual pulse check. So it was 0.44 times faster.
Yeah.
Which is, I think, significant because it's saying the opposite of what the echo ones are showing.
Yeah, exactly. So the real point here is that you can do it. You can have high inter-rater correlation.
Right.
And it's fast.
Okay.
And that's like the step one in building our argument for this, right? You can do it. It's fast. It's at a readily accessible location. It's out of the way. No one's going to slide off the chest with all the gel.
Right. No one's going to be in the neck.
Yeah. But I think, there's a couple, interesting parts of this is that, some patients, they were doing the ultrasound exam at the 2 minutes during the rhythm and pulse check, but they were also doing it in between as well, every 30 seconds during compressions.
Oh, okay.
And they were actually able to predict some patients that on the next pulse check had a pulse because of what they were seeing. Yeah. So I like that predictive kind of quality. And, maybe down the road, maybe it's reason to stop compressions early.
Yeah.
Right? Like, the implications are there. That's really cool.
Love that.
But at the same time, I still have these kind of questions of like, okay, so you see this tiny little pulsatile carotid, and you're just going to say there is a pulse, but I want to know, is that 20 over 10?
What does that mean?
90 over 60? Like,
right.
I don't know what that means. And just because I can visually see something, do we have a perfusing pressure to the vital organs, to the brain, to the heart? Right. And I don't think this study really answers that. They had a couple patients with A lines, right? We want a gold standard, but that really wasn't the point of this study.
Yeah, no, I like that. That's brilliant. So I had a couple thoughts, right? And we did, full disclosure, we did chat about this before, right? Because we're good at what we do. Do you remember in med school when we were taught that we could do carotid massage for vagal stimulation SVT?
Yeah.
And then do you remember how later on they're like, oh, actually that can cause dissections and be potentially harmful?
Ruptured some plaque, now they're stroked out.
Exactly, or stroke, right? So the average age in this study was 72 years old. So these are patients that presumably are higher risk at having blood vessels that aren't that great. So that's one of the things that I think about is that like if they're doing that, they're like kind of pushing, essentially doing a carotid massage every 30 seconds.
Yeah.
Potentially you might cause some harm, right?
Yeah, it doesn't really sit that well, I guess.
Yeah.
And I was mentioning before we started, I'm not stoked about the idea of compressing the IJ during CPR.
I see.
Because then you're impeding venous blood flow from the brain, and that congestion can, potentially increase your intracranial pressure.
Yeah, which can cause issues too. So like a couple things to think about. This is an interesting study.
Yeah.
And I like the idea, and I'm for it because one could argue that you're doing the same thing with your finger. So is there anything different? So, but it's just a question that I have, I guess, and it probably will never know if it actually leads to poor outcomes or not.
Just sits in the background.
Just something to think about, All right, so we have that, but wouldn't it be sweet, Terren Trott, if there was a way that we could use our ultrasound essentially identically to an art line? Because really, I talked about the art line's my favorite thing because I put that in there and it almost you don't even need an actual pulse check because during pulse check time, you just look at the blood pressure and if the diastolic is above 35, 40, you're perfusing enough, right? You always want to get higher than that, but perfusing enough, you can actually stop chest compressions.
Yeah.
So what if we could figure out a way to use ultrasound for that specific thing?
Well, that brings us to our next study.
Oh,
thank you very much.
How fortuitous.
Yes. This is our next study.
Wait, is it in resuscitation?
It sure is.
I knew it.
I know, man. I need to get a job there. Femoral artery Doppler ultrasound is more accurate than manual palpation for pulse detection and cardiac arrest. Resuscitation. I think also 2022.
Oh, this was 2022. I think.
Yeah. There's a bunch of studies. We're not even covering another one that looked at.
Yeah. Well, there's actually, we'll talk about it. I'll just touch on it, but there's one that just was published, 2023. Where they actually took extra data from this and published a second study. Yeah. So I'm excited about it.
This was a well-done study.
So well done.
And
to be fair to the other authors, to the other study, it was also a well-done study.
Yeah.
It's just this one actually gives us the thing that the other one didn't give us.
Yeah.
Which is a gold standard.
Yes.
Right?
So all of these patients had A lines. It's awesome. Nicely done.
Nicely done.
And they used femoral artery Doppler data and kind of correlated it with what the A line was saying. So
that's the data that we need.
Yes,
That's
exactly. So interestingly, we were talking about, what kind of A-line cutoffs you use in cardiac arrest. And I've been, I've heard myself say things like a MAP of 35 to 40. I know a lot of people use diastolic pressures. That's totally reasonable. All the data on this, I think like pig studies and stuff. You know? So, there's reasonable debate. This study said you should be getting compressions if your systolic is under 60, which may be a little high, honestly. But that's
you should be getting
compressions if your systolic blood pressure is under 60 on the A line.
Really?
It seems a little high.
Okay, that seems high to me.
I know, so they didn't use the
systolic,
diastolic.
not the diastolic?
Yeah, systolic. They didn't use diastolic.
Okay,
they didn't use
fair.
mean. But that's their reference.
Okay, great.
For as they kind of extract data. And then what they did was transverse view, femoral artery. They put the Doppler on, and they got signals. Right, and then they basically correlated the strength, maximum velocity of those signals to the A line.
Got it.
Right.
Yeah.
Cool.
Interesting. So that is literally, I'm actually looking at the study here, and I don't see where they don't have I don't see a reference on here. So I'm going to look at when we're offline and see if I see an actual reference. But I do see here that it says, secondarily, we sought to determine whether peak systolic velocity on Doppler ultrasound accurately detects a pulse with an adequate blood pressure needed for perfusion, which we define as a systolic greater than 60.
Yeah.
All right, fair enough. I mean, that makes sense.
Yeah.
But I'm
they probably could have run the numbers a different way,
right.
But that's just what they chose.
Yeah, no, that's fair. Now, a couple things. I always do Doppler in the long axis, and I make sure that my angle of incidence is less than 60. It's got to be like this, right? They did this in short axis, and they didn't do anything with the beam angle. So that was very interesting to me.
They had a comment on it. Now I'm forgetting it off the top of my head about why they did it that way. And I think it was
because it's easier to find.
I think it was just so that they third art specifically.
We'll find it. We'll put it in at the end. Okay, so that's interesting and good. And I want to think about that a little bit more, because if your angle of incidence is off, I don't think it will artificially increase your systolic velocity. I think it will artificially decrease your systolic velocity. So one could argue that you're still at a very specific value.
Yeah.
You might not be sensitive, but you're very specific. So if you see a peak systolic velocity, which we'll talk about, a certain number that they came up with here with their data, then the patient likely has systolic blood pressure greater than 60.
Yeah. Yeah, that's right.
All right. So, because I think that's an important consideration, right? Now, Terren, what did they find?
So they correlated all the different peak velocities on their Doppler with all the different systolic blood pressures. And they essentially came up with this scatter plot that if you had
I love scatter plots.
If you had a velocity greater than 20 centimeters per second, you were very accurate in saying that you had a systolic blood pressure greater than 60.
That's amazing. So they found, if we're looking at actual numbers here,
and then they compared it to manual palpation, of course,
which let me guess, was worse.
Yeah.
We know
so
this.
the number. So they said if you had a peak systolic velocity on Doppler of 20 centimeters per second, you had an accuracy of 95% of having a blood pressure greater than 60 on the A line. So that's awesome.
They had a Spearman correlation coefficient of 0.9.
Yeah.
Which is quite high,
Yeah.
right? It's like amazingly high. They showed that the accuracy, I don't know, did we mention how many patients they were? I don't remember if we talked about that. In case we didn't, it was 54 patient and 213 pulse checks.
Yep.
Accuracy, you mentioned it, 95% with the ultrasound Doppler versus 54% with manual palpation.
Yeah. And then,
Coin flip. It's coin flip.
Yeah, painful. And they go into this more in the article, but they also say say you're between 0 and 20 for your velocity, that again correlates with lower pressures. So maybe there's this kind of pseudo arrest area that might incline you to change your management one way or another.
We need to put them on an epi drip or norepi drip or something like that versus they're okay.
Yeah, exactly.
That's great.
So it's basically like having an A line.
Basically like having an A line that it's much faster.
And yes, so it's faster.
Yeah.
We can get good at this, right? We can do it in just a couple seconds.
Yeah.
And it correlates well with the A-line. So if we don't have the A-line, we know whether or not to do compressions, whether continue compressions. I think it's game changer.
I think it's huge.
They have the obvious, needs external validity.
Of course. And I mean, it was a good amount of pulse checks, but it was 54 patients.
Yeah.
In a single institution. It'd be great if we could have this and I think that this will give us that information.
Yeah. And then when you compare it to what our standard is right now, and we know our standard of mantle palpation is so bad that it seems like this really should be what we're doing.
Right.
So I personally plan on adopting this and maybe getting some of my colleagues to adopt it and see how it works for us, especially when we know mantle palpation is just not really cutting it.
It's just not good. And also, like, sometimes it's, can I tell you something? And you just not judge me for it.
Let's hear it.
The other day, I failed in a femoral artery line arrest.
Oh.
No, it hasn't happened in years. It's the end of this interview. It hasn't happened in years, but like I stabbed it and like the guide wire would not thread.
Back for some reason?
It was really weird. I got stool back. I don't know what that was all about. I got urine and stool back. I could see it in the artery, in the femoral artery, but like I couldn't get the guide wire to advance. I knew it was in the middle.
It happens, right?
I got a second line, still couldn't make the guide wire pass, and we ended up giving up on that art line, and then like went on without it. But this, like, you don't need it. Now we don't need it. And I think that I'm probably going to start like utilizing this. I don't know if where I'm at, like I'll be able to say like we're doing this instead of pulse checks, but I think that this is a good start. And the way that we create more data is by using it. And then we can create dialogue to say like, actually, this is a problem that we're having, or hey, we had actually great experience with this.
I mean, I would love to see, in 2 years, AHA says, when available, ultrasound determines pulse checks,
That'll be the next one when you're on like the committee or whatever yourself as a critical care doctor.
That's right.
All right, Terren, that was amazing.
That was awesome.
Thank you so much, and we can Zoom more.
Yeah.
Also,
we
Terren.
Should. Yeah.
What were you gonna say? Sorry, were you about to say
Subclavian.
Subclavian. Oh yeah, we got to talk about the subclavian lines. We got a lot of stuff to talk about.
Yeah, lots of stuff to talk about. Yeah. We'll have all these articles linked,
ready to go.
Yeah, and there's a couple more if you want to kind of grow your reading of this area. We can have them all linked on the site. And
there's also they just recently published a secondary analysis of this that included the end tidal CO2 actually. So it's like the same data point. Now I think I have it. Let's see. Hold on. This one? Yes. So this one's entitled Doppler Ultrasound Peak Systolic Velocity versus End Tidal CO2 during pulse checks. And we're not going to talk about this one in depth compared to the other one, but they base the data off of 35 patients with 111 pulse checks, and they found that the accuracy, let me find it here, the accuracy of their peak systolic velocity, showing a systolic blood pressure of 60 in that population, was 89% with the Doppler versus 59% with the end tidal.
So it beats out end tidal.
Yeah. We're talking about it, and I guess why would somebody have a low end tidal, a falsely low end tidal? It could be, I don't know.
All sorts of there's too many variables.
Right.
There's too many variables, and now with this, we're looking at exactly a blood pressure surrogate,
which I love,
versus all the perfusion mismatching and all this stuff. Awesome.
Well, I guess we're gonna go see a show right now, so we gotta get ready.
That's right.
All right. Well, Terren,
thank you so much.
I hope to hear from you soon, and happy scanning.
Thank you.
There is so much information that we can actually go through and gather, but this is just talking about these two studies. Hopefully in the future, I'm going to be able to go through a bit more of the literature to try and get it all figured out. I really hope this stimulates some good discussion because I want to know how you are using ultrasound in cardiac arrest. Are you using the linear transducer to look at carotid, to look at femoral pulse checks? I don't know. Why don't you tell me? Tell me what you think. Tell me what your limitations are. Looking forward to hearing from you soon, and happy scanning.